The podcast you are about to listen to is not a medical podcast, nor is it designed to diagnose a condition. While there are medical experts on this show, any questions regarding medical care or concern should be directed to a primary care physician.
The team at Imvax is dedicated to delivering new, personalized immunotherapy approaches to improve outcomes for people living with glioblastoma and other solid tumors. Leveraging decades of validated research and technologies, Imvax's unique platform is designed to capture a tumor's full antigen signature and use it to stimulate a patient's immune system against remaining tumor cells. Imvax, advancing a new approach to personalized cancer immunotherapy. Hey, it's your friend Shannon Traphagen, and welcome to the Game on Glio podcast. Here we tell the stories of brain cancer and tumor warriors, clinicians, medical experts, and those in the grief and loss community. Thanks to all of you for making our podcast one of the most popular podcasts globally. If you enjoy our show, please consider writing a review. Also share us with a friend and follow us on Facebook, Instagram, TikTok, YouTube, and our website.
This season of the Game on Glio podcast is sponsored by GT MedTech and GammaTile Therapy. Learn more at gtmedtech.com. Season 4 is also sponsored by Imvax, personalized whole tumor-derived immunotherapy. Learn more at imvax.com. This episode is brought to you by Mimivax LLC. Learn more at mimivax.com. This episode is brought to you by Highmark BlueCross BlueShield of Western New York. Visit mybcbswny.com.
Life should be humbling as we age. As we grow older, we stop chasing the big things and we start to value the little things. Alone time, enough sleep, a good diet, long walks, quality time with loved ones, simplicity, that becomes the ultimate goal. Within that is knowledge. As we grow older, as we age, we should all want to better ourselves with knowledge, education. None of us has all the answers. None of us should. This episode is a great reminder, even for me, that there is still so much to learn about rare diseases and rare cancers like brain cancer. There is still so much unknown, so much complexity. We should never get to the point where we feel that we have had enough years under our belt to know everything or to be set in our ways. We should always be willing to better ourselves, to improving ourselves, to be willing to change, to be flexible, to be open to something new, to new processes, new patterns, new ways of living life. In today's episode, there are quotes and statistics that can be jarring and even took me back. But when I take a step back and I think about the whole picture and what it represents, I realize that there is knowledge to be had within those statistics. There is a way that we can better ourselves from the information that's gleaned in today's episode. It offered me profound insight into the complexity of brain cancer at a molecular level. And I hope you all feel the same. We only have one episode left before the end of our 4th season. And as I've stated, we will have a 5th season coming to you in 2025, and we are so proud to be offering that. My team and I work so hard to put this show together, and we are so grateful to everybody who listens and to all of those who share. Our episode next month is about getting through the holidays when you're dealing with grief and loss. And we have a grief coach and a life coach. She is an expert in the field and she will be joining us then. Until then, I hope you all take away the same value in the knowledge and the information you receive from today's episode. We sit down with Dr. Horbinski from Northwestern University in Medicine after a brief word from our sponsor.
Our time is precious, especially when you or your loved one is diagnosed with a brain tumor or the cancer has spread to the brain. That is why GammaTile is here, the only FDA-cleared bioabsorbable implant specifically designed for the brain that delivers immediate radiation at the time of brain tumor removal. No more waiting to start radiation. No more of your precious time spent going to outpatient radiation treatments. With GammaTile, focus on what truly matters: your recovery, your strength, and cherished moments with loved ones. Discover GammaTile centers near you and find hope from inspiring patient stories at GammaTile.com.
This episode was brought to you by Mimivax LLC, developing immunotherapeutic vaccines and therapies for treatment of cancers such as glioblastoma. Learn more at Mimivax.com. Welcome back, everybody. Thank you so much for joining us here on the Game on Glio podcast. We have an amazing guest with us today, and I'd like to introduce him now. His name is Dr. Craig Horbinski. He hails from Buffalo, New York, where I live, which is very exciting, where he completed a combined MD PhD training at the State University of New York at Buffalo. He then did an anatomic pathology residency and a neuropathology fellowship at the University of Pittsburgh. As a full tenured professor at Northwestern University, Dr. Horbinski directs the neuropathology division, the nervous system tumor bank, and the pathology core facility for the Lurie Comprehensive Cancer Center. His main clinical interest is molecular diagnostics of brain tumors, and his primary research interest includes adult-type diffuse gliomas, especially IDH mutant gliomas and meningiomas. Dr. Horbinski, thank you so much for joining us today.
Oh, it's my pleasure. Thanks for inviting me.
I'm really excited to have you on as a guest. I have been wanting to have you on for quite some time because the work you do, I feel, is the work that is needed and necessary when it comes to trying to figure out new avenues to tackle such an elusive, rare cancer. So let's start with exactly what is neuropathology? You know, for so many of our listeners, we hear of neurosurgeons and oncologists, but what exactly is neuropathology?
Neuropathology is a medical subdiscipline that works to a large extent behind the scenes. So, for example, if somebody is suspected of having a brain tumor, if imaging suspects a tumor, and the patient undergoes neurosurgical biopsy or resection of the lesion, the material then goes to the pathology department.
Okay.
It's a huge part of healthcare. So, for example, whenever you get a blood test, it goes to the pathology department. The laboratory medicine aspect of the department analyzes and produces the results that are, then dictate therapy or treatment.
Okay.
Likewise, if tissue is produced, it goes to the surgical pathology subdivision within the department. And then it's processed, it's put onto glass slides, it's examined under the microscope with special stains and all sorts of other histologic studies that we use to assess the tissue. We determine whether or not it's a diseased tissue, and if it is, what kind of disease it is. Is it a tumor? Is it a neoplastic process, or is it something else? And then once we get that far out, we subtype the tumor, if it's a tumor, using additional special stains. Molecular testing is much more prominent now than it was even when I was a trainee. So that the idea is to have molecular testing enhance traditional light microscopy to produce extremely accurate results that are then used to inform prognosis and treatment and all sorts of other variables.
So it's a necessary part of the neurology field. This is very similar to when you have blood work done or when you have testing done for something like that might be COVID or for, UTIs that are sent out. Like it's always sent out for extra analysis to make sure that there's nothing else going on other than what they think the original underlying diagnosis is. But in the case of tumors, this is extremely important work. I mean, this is very necessary.
It is. It's very much like being a medical detective. And nothing can really happen until the diagnosis is rendered by a pathologist.
Okay.
Sometimes we're called the doctor's doctor or the physician's physician because we consult with treating physicians on what the disease process is and as a result, how best to approach the disease. And that goes for not just brain tumors, that goes for literally everything that happens in the body.
Yeah.
if we wasn't for pathology, the treating physicians, the clinicians would be flying blind. They literally would have no idea what to do.
So is it safe to say, I mean, if we're going to paint a picture of what this kind of looks like, it almost sounds like you guys are the aviation instruments for the physicians and the oncologists to do the work that they do, that you guys really help guide them on what needs to be done for next steps to help treat the patient the best way possible.
Yeah, that's a good analogy. Another one is that we're in the manufacturing business. We manufacture information.
Oh, I like that. Yeah, that's a great way to paint a picture. And this is what we want people to understand. There's so many dynamics and so many layers that go into tackling diseases and cancers like this. And you can't do one without the other. Right.
It all works hand in hand. And that's where one of the undersung aspects of pathology and radiology to a large extent, another specialty that to a large extent works behind the scenes, is communication with the treating physicians.
Yes.
And being able to discuss things and talk about them openly. If we're not sure about a particular disease or it's going to take a little extra time to figure out what's going on, we need to be able to communicate that effectively to the people who are directly taking care of the patient.
So now I'm really curious, what led you into this path? What led you down the road of neurology, neuropathology? What sparked that interest?
It was informed, as is often the case, it was informed by my educational experiences. So I knew when I was a little guy, maybe as early as 5 years old, that I wanted to be a scientist. I didn't know what kind. Then as I got a little older, I decided that I really wanted to be a physician. And that was informed by some experiences I had where I had to be in the hospital for extended stays when I was a kid. And that impressed upon me just the beneficent effect that physicians and nurses and the entire healthcare system can have on a person's life. And it just seemed like the most meaningful thing I could possibly do. So when I went into college, I went in with the idea of pre-med, of going to medicine. I wasn't sure exactly what kind of medicine yet. But then in the sophomore year of college, I took a neuroscience course. It was just phenomenal. It was extremely well run. I had guest lecturers from the University of Buffalo because I went to Canisius College. And so the nearby university, well, of course, the big university is the University of Buffalo. And they were talking about, epilepsy and neurodegenerative diseases. And it just, no pun intended, blew my mind. I thought, oh, my goodness, this is so.
It's fascinating.
What could be more profound and more important to study in a human than the human brain?
Right.
I thought, okay, I'm going to go with neurology. So I went into my MD PhD training at the University of Buffalo. I went in with neurology in mind, thinking that's what I would likely specialize in. Now, when I did my PhD years, my graduate student research laboratory years as part of the training, for one thing, I actually ended up in the laboratory of one of those guest lecturers who had spoken to us when I was still at Canisius College. So he was so impressed with his lecture, Dennis Higgins, that I wanted to keep an eye on it. And if there was a spot in his lab, I was going to join him. And so I was fortunate enough to be able to do so. But his lab involved something called developmental neuroscience. So it was studying how the nervous system forms.
Okay.
It's an incredibly complicated structure. The brain and spinal cord is the most complicated structure in the known universe.
Yes.
How it manages to form. It's really a miracle that we don't all have severe neurological defects.
Right. Yeah.
It's astounding that most of us come out as normal as we do, even if we have little quirks here and there. But what I was doing at the time, since it was so heavily involving studying neuronal development and morphology, I had to spend a lot of time at the microscope. I mean, like hours and hours a day at a microscope, fluorescent microscope in a darkened room, studying neuronal morphology and studying ways of treating the neurons and seeing how they change their shape in response to certain chemical signals. And just as time went on, it was a function of repeated exposure, day after day after day, month after month. I became pretty good at the microscope and developed a deep appreciation for what it can show you, much in the same way that a telescope shows an astronomer the universe.
Yes. Yeah.
The microscope reveals an entirely hidden world to us. And I get the same charge out of looking at very small things as an astronomer would looking at something very far away that's very large. So when it then came time to go back into my clinical clerkships when I was done with my PhD, and I was wrapping up the combined program, I shifted a little bit. I did rotate through neurology, and I thought, okay, neurology is fine, but gosh, if there's a way I can combine my interest in neuroscience with the microscope on a clinical basis, that would be ideal. As it turns out, there is a subspecialty within pathology called neuropathology. That's the subspecialty that focuses on diseases of the central nervous system.
Okay.
That is in contrast, for example, to gastrointestinal pathology, which,
Yep.
as you might imagine, focuses on like colon cancer and all those other sorts of things, or head and neck pathology, or hematopathology, leukemias and lymphomas. I mean, there's an enormous number of subspecialties within pathology. Medicine is a really big tent in its own right. Pathology is also a really big tent within that super tent.
I don't know if people would know that. I don't think that people really think about that.
Yeah, so there's subspecialties, and to be a subspecialist, once you're done with your basic pathology training, then you go on to pursue fellowships in various things. So you can do it in transfusion medicine, neuropathology like I did, head and neck pathology, thoracic pathology, genitourinary pathology, breast pathology, gyne pathology, anything you can think of, soft tissue pathology for like sarcomas and bone cancers. Now we've added new subspecialties. So now there's pathology informatics.
You know what? I have seen that.
And then there's, of course, molecular diagnostics and molecular pathology. That's a big one. That's a very popular one because there's so much demand for molecular diagnostics.
As you're talking about this, and this kind of leads me into the work that you've started doing over the years, over the course of the lifetime of this work that you've been focusing in. You really started to zero in on IDH, high-grade gliomas, glioblastoma, brain cancers, and other central nervous system rare cancers, CNS cancers. You direct the Nervous System Tumor Bank. Tell us a little bit about what is it your department focuses on? Kind of what does day-to-day look like for you?
We focus on predominantly infiltrating gliomas, mostly glioblastoma as a group, because that's of all the gliomas, that's the most common and the most lethal in adults.
Right.
So most of the laboratories around here are focusing on various ways of treating, new ways of treating glioblastoma.
Mm-hmm.
But there's a subset of us that focus on, including IDH mutant gliomas, which is distinct from glioblastoma.
Yep.
As well as meningiomas, which is an increasing emphasis of mine in my research lab. And we also have a specific meningioma working group, a multidisciplinary group within Northwestern that focuses on trying to develop new therapies, better ways of prognosticating how patients are going to do, all those sorts of things.
Within this, so we're talking about IDH mutant. There's also IDH wild type.
Yes.
And for any patient that is out there that is listening to this, they're very familiar with these terms. Within glioblastoma, so for example, my late husband had glioblastoma, and usually when glioblastoma is detected, it's almost always a stage 4. If you can catch it earlier, you're very blessed. But it's almost always a stage 4 at that point. My husband, for example, his tumor DNA came out it was IDH wild type within the glioblastoma of his tumor. Can you explain that a little bit? How, there's different distinctions within the makeup of the tumor itself.
So first of all, the notion of IDH wild type versus mutant, this is where things get a little complicated because IDH wild type gliomas come in one of two extremes. Either they're the extremely lethal ones like the glioblastomas,
right,
or they're the extremely treatable ones, which are what we now call circumscribed astrocytic gliomas, like pleomorphic xanthoastrocytoma, pilocytic astrocytoma.
Interesting.
Things like that. So just because something is IDH wild type does not automatically mean it's a glioblastoma.
This is good. Okay.
It could be.
Yes.
And in many cases it is true, but just because something's IDH wild type doesn't automatically mean it's terminal.
Okay.
Whereas IDH mutant glioma is something in between. So it's a relative thing. When we say it's got a better prognosis, yeah, that's relative to glioblastomas.
It's like splitting hairs.
Yeah, I mean, so it still is ultimately progressive. It's ultimately going to be fatal in most instances. It's just that it's going to take a lot longer. Your prognosis, you're going to live longer. So when we say favorable prognosis, it's a relative term.
So somebody who has IDH mutant glioma, it's still something that's going to catch up to you down the road, but it might be more manageable. There might be more ways to kind of get at it, to treat it. You'll live a little bit longer. IDH wild type can kind of split to two different avenues, you're saying, and one is more treatable. The other is glioblastoma, which is just, it's a bullet to the heart.
Yeah, it's a really hard to treat glioblastomas. And that's where, having these tumors evaluated at centers that see a lot of them.
Mm-hmm.
I mean, we diagnose hundreds and hundreds of brain tumors every year here at Northwestern.
Wow.
Almost 1,000, I think, based on my last call, my last count, rather.
Jeez.
So that includes everything from metastatic cancers to primary tumors of the rise in the brain.
Okay.
Benign, malignant, everything in between. So we're pretty well trained on what to spot, what pitfalls to avoid.
Mm-hmm.
And we have the molecular testing as well to add a layer of so-called protection. In other words, we see something under the microscope and we think, ooh, this looks like tumor X. Then we'll do molecular testing to prove or disprove our impression.
Dive into genotyping a little bit. Is that part of the molecular testing that you're discussing, or is genotyping kind of a different avenue when it comes to looking at these things, dissecting these tumors, doing the pathology? Describe genotyping a little bit as it relates to the pathology of looking at brain cancers.
Genotyping is more or less used interchangeably with molecular testing. Molecular testing just refers to, molecules, meaning super small substances, in this case, testing the DNA
mm-hmm.
of a tissue, a tumor, to see what patterns it has, what mutations are in the DNA that might be diagnostic or prognostic. And then on a slightly larger scale, what gains or losses of specific segments of the tumor's genome are present that also might inform diagnosis and prognosis.
What kind of information could that give you or give the patient in doing that kind of molecular work?
Well, for example, if I get a case, and I don't even need to look at it under the microscope necessarily, but if I get a case where the molecular report says there's an IDH mutation, a TERT promoter mutation, and loss of chromosome 1p and 19q, then I know that it's an oligodendroglioma.
Interesting.
It's that stereotyped. I don't even need to look at it.
Okay.
I mean, we always would, of course, look at it under the microscope just to verify, but it's that characteristic of an oligodendroglioma.
Mm-hmm.
On the other hand, you could get a molecular report that says it's got a TERT mutation, but it's IDH wild type, and it's got EGFR amplification, gain of chromosome 7, loss of chromosome 10. Well, that's a glioblastoma.
Interesting. Okay, so literally looking at the makeup of the tumor itself can tell you what DNA strands, what kind of, how this glioma has formed and the best way to go about treating it. That's really part of what the genotyping is doing for you.
Yes. And it helps too, because sometimes, in most cases, the molecular aligns perfectly with what we thought under the microscope.
Right.
So we think a microscope is a certain way, the tumor looks a certain way, and then molecular confirms it. Great. It adds another layer of confidence that the diagnosis is correct. We call it the Swiss cheese model. So in other words, in any institution, if you want to avoid errors, whether if you're in aviation,
mm-hmm.
if you're running an airline,
yep.
or you're building reliable cars, or you're doing healthcare, the idea is to have multiple orthogonal layers of testing evaluation where the holes in each modality has its strengths and weaknesses.
Mm-hmm.
The idea is to pair up or layer up a number of testing approaches that complement each other, so the odds of a particular error getting through all those different holes in the different layers of Swiss cheese is very, very low.
Okay.
The error rate, we're trying to minimize error. And so what this does for us is that when we see something under the microscope, we think, oh, gee, it looks like a low-grade tumor, but we run it through our molecular testing and we find TERT mutation, gain of chromosome 7, loss of chromosome 10, EGFR amplification. We're like, oh dear, okay, so it's actually a glioblastoma, even if it looked like a lower-grade tumor under the microscope. And vice versa, if we get a molecular report,
mm-hmm.
and it happens thankfully extremely rarely, but it can happen, where you get a molecular report and it doesn't seem to align at all with the histology. It's like, wait a minute, I was expecting this tumor to have a BRAF mutation, and this tumor has no BRAF mutation. His report does not indicate a BRAF mutation. It doesn't match the histology at all.
Okay.
Well, then that's a clue that maybe we better go back and make sure that there wasn't some sort of error somewhere in the process, that the correct tissue was analyzed, and that we're looking at the report that truly matches that patient's tumor.
Okay. So let's add another layer to this. We're talking about all these redundancies that are put into place to make sure that we know exactly what it is we're looking at and dealing with that came to us under the microscope. How does methylation profiling fit into this? What exactly is that layer, and how does that fit into treating brain cancers like glioblastoma?
Well, that's a great segue. So that is another new modality, new testing that adds another layer of security on top of everything else we've already talked about.
Mm-hmm.
So in a given cell, any cell, doesn't have to be a cancer cell, the genome has hundreds of thousands, well, really millions of sites where it can be chemically modified. And it sounds scary. It's like, oh my God, my DNA is being modified chemically. But this is a perfectly normal process. It's how the cell turns on and turns off certain genes according to its own needs. That's why the exact same genome can give you either a skin cell, a lung cell, or a brain cell.
Okay.
Certain genes are turned on and turned off. And one of the mechanisms by which genes are turned on or turned off is methylation. So it's really just adding a little carbon atom with 3 little hydrogen atoms to specific spots in the genome. Well, as it turns out, in normal tissues, you can tell the lineage of of any cell by looking at the patterns of where it's methylated, where those little carbon atoms are attached, and when they're not, where they're not. On a binary level, it's like either at a given site, it's either methylated or not. So it's literally a 1 or a 0.
Okay.
It's really digital information. It's either a 1 or a 0. So those sequences of 1s and 0s across the entire genome produce a pattern that reveals the identity of that cell, of that tissue. And the same goes for tumors. So within the context of the brain, where you can have over 120 different kinds of tumors in the brain or spinal cord, each of them, including subtypes of tumors, have their own unique methylation fingerprint. It's really in some sense like a fingerprint. We're able to interrogate that and determine where those 1s and 0s line up and reveal the identity of the tumor. It can be extremely useful. For example, if you sequence a tumor, it'll find pathologic, cancer-causing mutations that aren't necessarily specific for a particular tumor type. Like, for example, you could do sequencing and find p53 mutation paired up with deletion of CDKN2A/B. Okay, fine. There's a lot of tumors in the entire body that can have that kind of molecular alteration. Now, that's not going to tell you what kind of tumor it is specifically in the brain.
Right.
But if you run it through molecular profiling, that fingerprint will then reveal the identity of that tumor. And it's so robust that I can tell, for example, if something is IDH mutated or BRAF mutated or something like that without even necessarily doing the sequencing, because each of the molecular signatures is so tightly associated with certain driver mutations like IDH or BRAF that the molecular fingerprint, the epigenetic fingerprint, the methylation pattern, reveals the underlying driver mutations.
So now, is it possible, or is it reasonable to say, it almost sounds like what you're describing and what you're talking about is really, you're going in, you're looking at the fingerprint of this tumor, and we'll use glioblastoma, for example. You're going in, you're dissecting the makeup of the glioblastoma, you're going through the molecular, the genotyping, all of the pathology. Then you're adding methylation profiling to figure out what cells have been turned on or turned off to feed this tumor. So let's say there are other cells that are identified through the methylation profiling that are usually found in other types of cancers. Is it a reasonable assumption to say that that could be helpful in finding new combinations of chemotherapy to really target the glioblastoma itself, because there are other cancer cells woven into the makeup of the glioblastoma, and so maybe these other chemotherapies would work in conjunction with the temozolomide?
When you're talking about cells, I think you may be referring to genes within
yes.
in the cells.
Yes.
So the short answer is yes. Like, for example, in meningiomas, we're finding out in our own laboratories research that there's and others have been showing this as well, that there's 3 major methylation subclasses of meningiomas. We're screening these meningiomas against a variety of chemotherapies and finding out that different subsets of meningiomas respond differently to different kinds of chemotherapies.
Interesting.
There are ways of using the methylation patterns in specific tumors to inform on therapies. A lot of this is still nascent. It's still in its embryonic stage to some extent. So it takes many, many years of painstaking research, expensive research, to translate those sorts of findings into clinically usable therapies.
But it's a step. I mean, this is,
Yes.
we need to be taking these steps in order to treat these types of really deadly cancers, especially because when you look at the statistics of the individuals that are being diagnosed every year with high-grade gliomas, with glioblastoma, a lot, I don't want to say the majority, but I would hazard a guess that at least 65 to 75% of the individuals diagnosed are under the age of 55.
Glioblastomas? Well,
Just with brain cancer. I mean, brain cancer, and I mean, at least from what I've seen and from the people that I've talked to and the doctors that I've worked with nationally, even globally, I've met very few individuals patient-wise who are over the age of 65 that are diagnosed with brain cancer. And I don't know what that translates to or what the meaning of that is or the makeup of that is. But I've met so many individuals in their 20s, their 30s, their 40s that are being diagnosed with, an astrocytoma, some type of meningioma, some type of high-grade glioma, some type of glioblastoma. But there seems to be a prevalence with a lot of younger individuals being diagnosed.
What you're experiencing is what we call selection bias.
Okay, just what's that?
Actually, as it turns out, meningiomas and gliomas increase in risk as one ages. So you'll see your relative risk of a glioblastoma is a lot higher when you're 70 than it is when you're 50 or 30.
Interesting. Okay.
But the reason you're running into these younger people is because if you get a tumor like that when you're older, it tends to be more aggressive, and the patient's brain, it's an older brain, so it's less able to withstand, at least for a while, the cancer as well as associated radiation and chemotherapy. So you haven't run into too many octogenarians with glioblastoma because, frankly, they don't tend to live very long.
Interesting. So this is really, really fascinating because this is such a huge conversation globally, even nationally. And it seems like, kind of what's put on our radar are these individuals that are younger because their brains are able to at least live a little bit longer. They're able to handle it and go a bit longer with the disease than those that are of an older age.
Yeah, and also the younger you are, so when you're in that 20 to say 45-year-old group, your chances are relatively higher. If you're going to have a glioma, it's going to be an IDH mutant glioma, or it's more likely to be. You get beyond 55, 60, and the chances of having an IDH mutant glioma drop substantially.
So there's an increased likelihood for it being wild type or it being glioblastoma.
Yeah, the older you are, yeah. And that's why, for example, when I go to Brain Tumor Foundation, patient family retreats and everything,
yep,
especially when I see patients year after year after year, it's enriched for the younger crowd, like you're talking about, who have relatively less aggressive tumors, like lower grade meningiomas or oligodendrogliomas or something like that. There's an enrichment for those people because, frankly, the people with your stereotypical IDH wild-type glioblastoma, they're not going to be able to last as long.
Right. So this is very hopeful. And I'm glad that we're having this discussion because it really paints an amazing picture, puts into perspective this idea that if we have to be talking about a hard disease like brain cancer in general, there are a lot of these variations, and the chances of getting glioblastoma IDH wild type are really less likely. When you get older, it opens that door a bit more. But when you're younger, if you're diagnosed with a brain cancer, more often than not, and we're not saying that this never happens, but because my husband is a perfect example of somebody who ended up with IDH wild type, who ended up with glioblastoma at 44 years old and ended up with leptomeningeal disease, which is extremely rare. When the primary brain cancer is glioblastoma, it wasn't a metastases to the brain. It started out as glioblastoma. And he only had 14 months. And so, It almost seems like he was still a rare story among the brain cancer journey in general.
This is where by having a good understanding, a good working knowledge of biostatistics helps a lot.
Yes.
There's a lot of things that we get the impression, a visceral impression, because we're all humans.
Yep.
And like, for example, in my line of work, being at the big brain tumor center where I literally see brain tumors every day, I get a false notion of how common it is in the population. And I have to remind myself, okay, yes, we see 20,000, maybe 20,000 new gliomas per year in the United States, but that's out of a population of 340 million people?
Yes.
So there's a denominator there that I'm losing because, of course, the patients who have these brain tumors are coming to places like Northwestern.
Mm-hmm.
And likewise, this actually also is a really big thing where you'll run into groups or people who swear up and down that there's something in their neighborhood because 2 or 3 people in the same block all had a brain tumor.
Yes.
And so they'll think, there's got to be something here. It's power lines. It's something in the water.
It's an environmental factor.
Not to discount that, but actually, if you think about it from this is the analogy I try to use when I'm talking to somebody like that. If you take a bag of marbles and you're in a wide open space, you throw them up in the air and they hit the ground and they all bounce in different places on a flat surface. If they all landed and stopped, when they stopped, that they were each evenly perfectly spaced from each other in every direction, that would be freaky. That would be impossible, right? Just imagine that in your head. What's the likelihood of something like that happening?
Right.
The same goes with a stochastic process like cancer. If you don't have little clusters here and there of a weird kind of cancer that happen across an entire nation like ours, if you don't have that, that would be weird. If they're evenly spread everywhere, that would be a highly statistically improbable.
I read something very fascinating paper by a neuro-oncologist not too long ago, who's also somebody of kind of a faithful nature. And he wrote this really fascinating paper that talked about this negative connotation around cancer in general, let alone rare cancers, and how we have a tendency when it's affected us, we have this tendency we're now so observant of it. Like you were saying, you're seeing tumors all the time. You get this tendency, your brain almost becomes habituated to this idea that it's happening more and more and more. Well, the fact is that it's just on your radar more. And so you're seeing it more because you're open to it more. And for the statistic of, I think he said, 1 out of every 3 people will develop some type of cancer in their lifetime. That can make everybody very anxious. But he's like, but what people are forgetting is that means that 2 out of 3 people will not be touched by cancer. And we tend to negate that statistic and not look at the positive piece of that. When we talk about this idea of brain cancers and populations of people that are getting it, there is this sense of awareness to it being present. And so this idea of it's happening more and more and more, and what are we doing that's causing it?
And that's another thing, too, that we run into a lot. It's completely understandable. If somebody gets a cancer, especially if it's a rare cancer, then they think, oh, my God, what did I do? What was it? The dental x-rays? Was it this? Was it that? All sorts of things that especially, and this is especially tragic when, some poor kid gets a nasty cancer and then the parents are blaming themselves. The truth is, and this is our best data, really detailed bioinformatics analyses of cancer mutations and the frequency of mutations and everything. The best data, aside from those inherited syndromes that do exist, in most cases of what we call sporadic cancers, it's truly just dumb, rotten luck.
That's going to be a hard pill for some people to hear.
It is. And I know, because everybody understandably wants to have a cause attached to it. In some ways, that's comforting that there was a cause. But in most instances, that's actually not the case. In most instances, it's just rotten luck. Now, there are things you can do to modify your risk. So, a better diet, exercise, quit smoking, cut back on the alcohol, all those sorts of things. There are things that you can do to minimize your risk, or at least modify your risk to some extent. Ultimately, it's not comforting, I understand, but ultimately it's still just a matter of being at the roulette table.
It's just where the marbles end up falling.
Yeah, and it reminds me, too, of a joke you were saying, 2 out of 3 people don't get cancer. But keep in mind, that's also going to include somebody who dies of a car accident when they're 20.
Right.
They didn't live long enough to get that cancer. So it reminds me of that old kind of a dark joke. I'm not afraid of dying. I just hope it's of nothing serious.
Yeah, I've heard that joke before. Actually, I haven't heard that in quite a long time. Let's dissect this a little bit. So, when it comes to the genetic makeup of the tumors, and, this is kind of where we've been going with this. I mean, when we look at the transformation of the field right now, and in all honesty, I have been seeing this amazing transformation, this energy in the field of neuropathology, oncology, neurosurgery, just in the last 5 years. And I know that this has been going on behind the scenes for quite some time, but there's been this resurgence or uptick, if you will, in the last 5 years. Do you think that being able to dive into the genetic makeup, being able to get even more in depth when it comes to like methylation profiling, do you think that this could really be a game changer when it comes to treating brain cancers like glioblastoma, down the road?
For sure. It's like anything else. The technology drives the field.
Mm-hmm.
So the reason we're able to do a lot more than we could even when I was a trainee is because the technology is such that we can interrogate these tumors on a more cost-effective basis than we ever could before. And we're approaching, for example, the point where we're going to be able to, in the not too distant future, diagnose a patient with a tumor just by doing a spinal tap, even before the first neurosurgical incision.
Okay, so by doing a spinal tap, so let's say, if there's no cancer within the CNS fluid, is it something that can be preventatively done?
No, you wouldn't want to do it on a screening basis. First of all, spinal taps are not very pleasant.
No, they're not. My husband had one done.
Yeah, they're not pleasant. That would be reserved for somebody, for example, who had neurologic symptoms. You do a brain scan, you find out that they got some sort of lesion in the brain. It could be a tumor, it could be something else. So let's do a spinal tap and analyze some of that cerebral spinal fluid to see if it's a tumor, and if it is, what kind. And that just gives the neurosurgeon that much more information going in on how to manage that thing.
That's amazing.
Yeah, and that would not have been possible without some really extraordinary new technologies that are coming out where you can get a good, solid genetic readout of a tumor based on as little as 10 nanograms of DNA. And that's just, take my word for it, that's an insanely small amount of DNA. Just 10 years ago, that would have been unthinkable.
It's exciting to know that this is where we're advancing to. A lot of the research and the work that you've done, and when I say this, I emphasize this, you have been doing a lot of research and a lot of study when it comes to the makeup of these brain cancers and CNS cancers and how these things behave. One of the things that you did, you published a paper not that long ago on post-operative risk for IDH mutant gliomas as it associates to seizures. So a lot of times patients end up developing a seizure issue post-operatively. Post-operatively, for those who don't understand or don't know, means after surgery. And there's potential management with that for IDH mutant inhibitors. Can you talk a little bit about that paper and what it revealed to you in doing that work?
That was an interesting study.
Yeah.
It speaks to what I've been trying to do over the years. You may have heard the term, or people in your audience may have heard the term bench to bedside.
Yes.
Where laboratory-based investigations are hopefully going to drive better treatment.
Mm-hmm.
But there's also this reciprocal relationship where it's bedside to bench, where patient-based observations can inform new research projects that then hopefully are translated into better patient care. So for the longest time, when I was younger, we were taught that, and this is before IDH mutations were even discovered.
Mm-hmm.
So this is going back, 20 odd years. We were told that lower grade gliomas, paradoxically, were more likely to cause seizures than high grade glioblastomas.
Interesting.
Nobody could figure that out because if intuitively you would think a more aggressive tumor would cause seizures more frequently.
Yes.
That was not the case.
Okay.
So as it turns out, when it became feasible to sequence lots of different cancer genomes at a relatively high accuracy and low cost, that's when these mutations in the IDH gene were discovered. Because prior to that, nobody in their right minds would have thought that IDH1
mm-hmm.
or IDH2 would be mutated in any cancer, much less a glioma. There was no mechanistic reason to think so.
Right.
But they came up when you cast a wide net, interesting fish pop out of the net. And that was one of them. And as the field matured and more gliomas were being tested for IDH mutations, and we were studying the disease patterns in these patients, we found out that, it's the IDH mutant glioma patients who are much more likely to present to clinical attention with a seizure. As a result, then, when you follow them over their disease course, when the tumors recur, when they grow back, because after you treat the tumor, you debulk the tumor surgically, you treat it with radiation chemotherapy, the seizures drop.
Mm-hmm.
But then if the patient is doing fine for the longest time, then has a breakthrough seizure, better watch it because that tumor may have grown back.
Right.
What we were able to do then was to figure out, okay, the IDH1 and IDH2, these are enzymes that normally produce something called alpha-ketoglutarate.
Yep.
It's a chemical that your body needs.
Mm-hmm.
The mutant enzymes instead produce something called D2-hydroxyglutarate, which is a chemical that your body does not need and does not really want to have around too much. And as it turns out, through this was years of really painstaking research, we determined that in these IDH mutant gliomas, that chemical is secreted by the gliomas into their microenvironment, which means the brain. And in kind of oversimplifying things a bit, that D2-hydroxyglutarate is a neurotoxin.
Interesting. Okay.
It triggers the neurons don't like it, or they don't like it having it around. It irritates them and it causes them to fire uncontrollably.
Which in turn creates...
That's a seizure. And so what we found is that one of the side effects or benefits, I guess you could say, of the IDH mutant inhibitors is they can help seizure control. They can help improve seizure control.
This is really... Okay, my mind is just reeling right now because for somebody who's been personally touched by this, I have to say that I have been, with everything that I have learned scientifically over the last 4 to 5 years and really being entrenched in this work, it fascinates me how these tumors operate and what they do to survive. Everything that you're talking about, it just confirms that these are tricky tumors. They find what feeds them and they negate what's going to harm them. And that's where individuals like you come into play to figure out, okay, how do we turn off what's feeding it and turn on what's going to kill the sucker?
Yeah, it is. It's microevolution on an accelerated scale. In fact, that's one of the challenges of treating, well, really any cancer, not just glioblastoma.
Correct.
For example, let's say somebody presents, this is a classic thing, where somebody will present to the clinic and say, gosh, I've been having these headaches and they're not going away. Well, how long have you had the headaches? 3 months. Let's just say 3 months.
Mm-hmm.
And then, they'll work them up and, they may eventually lead to a scan and find out, oh dear, you've got something in your head. And so then you operate, you find out you have the glioblastoma. Now, if you ask that person, you ask their family, when did that cancer start? Well, it must have started 3 months ago because that's when I had the headaches. Actually, that's not true.
Mm-hmm.
Our best data now indicates that the inciting molecular alterations that drive glioma formation happen at least 7 to 10 years before clinical symptoms manifest.
Wow.
Yes.
7 to 10 years.
Yes.
So this is stirring in somebody's brain 7 to 10 years before presenting symptoms.
Exactly. And it might be, okay, so let's say you have some sort of neuronal glial progenitor cell that picks up, I don't know, a P53 mutation. Let's just say that alone is not going to cause a cancer.
Mm-hmm.
But maybe if that cell then at some point adds a TERT promoter mutation or an EGFR copy number gain or something like that, it's usually the general rule is it takes about 3 hits in 3 different pathways in a cell for it to become fully malignant.
Wow.
Roughly speaking, that's painting with a broad brush, but that's a general rule. So then that speaks to what we were talking about before, where it's really a numbers game, because God knows how many times any one of us have had 1 or 2 cancer-causing mutations arising in some sort of progenitor cell, but hey, for whatever reason, it never got that 3rd mutation. So what's happening? Eventually the cell either just peters out and dies on its own, or the immune system sniffs it out as being a little funky.
Which is what the immune system is supposed to do. So basically, if our immune system is functioning the way it needs to, hopefully it's attacking these things without us even being aware of it for the most part. Yeah,
you're blissfully unaware how close you came to cancer, to a terminal diagnosis. I know it's unsettling. And those are the sorts of research papers that I hate reading, but they're really interesting.
I think it really highlights the need for everybody to really appreciate the life that we're given on this earth, because I just feel like it is just that precious.
One of my favorite writers was Lewis Thomas. He was a physician. This is going back many decades now. Really, really gifted writer. And when he was dying, I think he was dying of terminal cancer, if I recall correctly, he was asked towards the end stages there if he was bitter, if he was, angry, or, how did he feel about having this go wrong? And he said, I got to tell you, I'm just astounded that it ever worked in the first place.
Wow. Oh, yeah. Yeah. That he was, yeah. That's really profound. It's great insight from somebody who's, on their last days.
Granted, facing one's mortality is that's what we all have to face eventually. And then that's where even science can only get you so far. Mm-hmm. It can tell you how the body works, but it has nothing to say about the soul or afterlife or anything like that. Just in the same way that we know science can tell us how to build a nuclear bomb, it doesn't tell us when or whether we should ever use it.
Or the aftermath.
It's a phenomenal tool. Nobody's a bigger fan of science than me, but I'm not a fan of what's called scientism, where it's used as a surrogate for ethics and morality and religion, because those still, even in the 21st century, they have an extraordinarily powerful role to play in our society and in the overall human condition.
I think that's the crux of all of this. There's this great sci-fi quote, and I can't remember the precise movie, but it's one of my Marvel movies, I'm sure. With great power comes great responsibility. And it is like that. That is literally the work of neuropathologists like yourself, researchers, clinicians, anybody in the science field that is really trying to understand the makeup and the genetics of the human body. With great information and knowledge comes great responsibility.
Oh, yes. In fact, one of my hobbies is, in what little spare time I have, is reading great works of literature, including ancient works, because the people from thousands of years ago have something to tell us today.
Yeah.
Because human nature has not changed. I don't care what anybody says. Human nature has not changed. And one of my favorites are stories involving dragons, because that's an archetype that spans all kinds of different cultures.
Interesting.
All across the world. And it's the same thing every single time. A dragon is something that's very intelligent and very powerful, but lacks wisdom. And something that's very intelligent and very powerful, but lacks wisdom, can do an incredible amount of damage. That's a lesson for all of us.
I love that. It is a lesson for all of us. And it's something I really hope that it's something for all of us to hang our hat on. And for everybody who's listening, I hope that you weigh that you really carry that piece of wisdom, because I think it's something that we all need to be more aware of. Let's turn a little bit to something fun, because we're talking about such heavy topics, but you do hail from Buffalo, and I'm going to assume that you're a Buffalo Bills fan. Or are we a Chicago Bears fan?
Oh, no, I'm loyal.
Okay.
It's a calling, though. It's a calling. Let's face it. And I remember, of course, in my formative years, it was those 4 consecutive Super Bowls, and I lived and died by the Bills.
Painful years.
As time went on, I learned as one grows up to learn to temper that a little bit, because it became ridiculous if the Bills lost on a Sunday for me to be miserable the rest of the week. Well, I had no control over that. That's just foolish.
Right.
So eventually I got over that, although I still watch them. I still root for them, obviously. And if they ever win the Super Bowl, I'm going to go nuts. I'll probably fly back to Buffalo just to join in the celebration.
Okay, well, we've got this recorded, so I'm going to hold you to that. When you do get back to Buffalo, if you ever come back to visit, or if you're up here for conferences, is there a favorite place that you like to go to eat, or like a staple, or somewhere where you're like, okay, if I'm here, this is where I'm going to get some food?
And the other thing too, I should mention, I'm a huge hockey fan, so I love the Sabres.
Do you?
In fact, I'm in my office right here. I don't actually have any Bills paraphernalia in my office, but I've got a big Sabres logo in my office here at work. If it's hockey season and I can get to a Sabres game, I always go to Pearl Street Brewery, which is just within walking distance of the arena, because they've got excellent food, a lot of great Polish food.
Yep.
Terrific selection of beverages. You can do play pool. So when I was in college and med school, we would always go, a bunch of us guys, a few hours before the game, and just shoot pool and have food and everything. And then we'd go over to watch the game, and we'd have a ball. It was just fantastic, especially back then, because the Sabres were really, really good back then.
They're working their way back.
Yeah, hopefully. I mean, Lindy Ruff coming back as a head coach, I think, is a big plus because he was the head coach in their strong years back then.
Everybody's excited about that. Yeah.
When they're not in season, like if it's during the summer or something, I usually try to swing by Duff's, the original Duff's on Millersport and Sheridan.
Yes.
It's in Buffalo. If you do wings, you're either Anchor Bar or Duff's, and I'm just a diehard Duff's fan.
Yes.
So that's the original. I mean, you can smell the wings even like from a half a mile away when you're getting close when you're driving up to the place.
Oh, your mouth just waters instantly.
Oh yeah, it's like a Pavlovian dog.
Yes, it is.
And I always get the hot wings too. So
you brave man.
And my wife and kids think I'm nuts, but it's just like, okay, if it doesn't sting a little bit, you didn't really have wings.
Yes, and there are no wings better than the wings in Buffalo.
Yeah. In fact, I even get wing sauce shipped from Buffalo to Chicago, because I'll do my own wings up at home.
Do you really?
Yeah.
My brother lives down in Florida, and he's like, you have to send me a care package with wing sauce every year for Christmas. That's just a must.
Yep, I get Duff's wing sauce and Chiavetta's chicken marinade.
Yes.
I don't know if you've ever had Chiavetta's chicken's phenomenal.
Yeah, you can't live in Buffalo without knowing what those things are.
If you're in Buffalo in August and you don't go to the Erie County Fair and have Chiavetta's chicken, then
you've missed out.
You just haven't had the experience.
You've missed out. Yes. Oh, this is great. For anybody that, Buffalo is such a great place. It really is. And there's just so much livelihood, and the food is spectacular here, but there's also so much history and culture in the area. And Duff's, I'm honestly torn between Duff's and Anchor Bar. I'm not sure which one I enjoy better. I used to judge the Chicken Wing Festival every year. And
oh, wow.
Yeah. And so I've always been torn on which one is better, but I absolutely love, especially during football season, chicken wings and football, they go hand in hand.
Yes.
Yeah.
Yes.
Yeah. I really, really, really want to say thank you so much for doing this. I think that this is an episode that we have needed for quite some time. It really peels back the layers on the work that's being done behind the scenes on a molecular level, that to really understand rare cancers like glioblastoma, IDH mutant, high-grade gliomas, that there are unsung heroes, that there are people behind the scenes doing really important work to help patients and families get to a point where maybe this can be more manageable at some point down the road and is not a bullet to the heart.
Yeah. That's our goal. My goal is at the end of my career, whenever, hopefully, not too soon, but maybe 20 years from now, that I'll be looking at a brain tumor with a trainee of mine and say, look, I remember when I was a trainee, this thing was a death sentence, but now we can do something about it.
I love that. There is so much hope in this arena. There really, really is. And that is the biggest message that I want people to take away from all of this information and all of this knowledge, is that there is so much hope and there is so much work going on behind the scenes, and we will get there. It's a waiting game. And for some people, they may not live to see the work that's being done right now, but for others, you never know.
Yes. And that's something that we try to convey to the patients, and even the ones nearing the end of life, say, look, we're going to get there someday. We're really sorry it didn't come in time for you.
Mm-hmm.
But if we don't keep trying, then we're never going to get there.
And we have to look at the lives that it could save 5-10 years from now, 20 years from now. It could really benefit, and it will benefit people down the road. For people who want to learn more about the work that you're doing, if they want to learn more about methylation profiling, or let's say there's a patient that says, I want a sample sent out to the lab. I want to have profiling done on my tumor to see what's going on. Where can people go to learn more about your clinic, the cancer center that you work at, and methylation profiling?
Well, if you wanted to contact us directly for consultations or whatever, you can Google Malnati Brain Tumor Institute. That will come up.
Okay.
Conversely, you could Google my name, Craig Horbinski. I'm fairly certain I'm the only Craig Horbinski on the planet because that's such a strange combination of names. At least I've never run into anybody with that name before. The nice thing, too, about what we do concerning pathology, the patient doesn't necessarily have to fly to Chicago or come to Northwestern to get their pathology reinterpreted at our facility.
Patients can be they can advocate, to the current lab at the cancer center that they're at and say, look, I want this sent over to your lab, over to your clinic at Northwestern. And, I want a second opinion on this. I just want to get this looked at over here. They can absolutely have that done without having to physically go in to your center.
Yeah, because legally the hospitals are custodians of these tissues, but they still belong to the patient. So if a patient says, I want it to go over here for the second opinion, the hospital will always honor that.
That's great information to have. And it's important information to have. This is all, it's knowledge, it's education, it's advocacy. And, we all need to be open to learning from these diseases. So I will have all of Dr. Horbinski's information up on our website with hyperlinks. And I will also have information about methylation profiling, what it is, why it's important. For all of those listening, thank you so much for joining us. And to Dr. Horbinski, thank you so much for your time today and the knowledge that you've shared with us. This has opened my eyes and taught me something, and it's given me a lot to think about, and I'm sure it will others as well.
Oh, you're most welcome. Thank you very much.
Thank you so much. And with that, everybody, we will be right back. A proud episode sponsor for the Game on Glio podcast, Highmark BlueCross BlueShield of Western New York has helped millions of members since 1936 lead healthier lives. As a community-based not-for-profit health plan, Highmark BlueCross BlueShield invests millions of dollars each year to strengthen and enrich the health and quality of life in Western New York. Highmark BlueCross BlueShield provides a wide variety of health and wellness initiatives, including free fitness classes and farmers markets throughout our community all year long. For more information or questions on our initiatives, contact us at communityrelations@highmark.com or visit mybcbswny.com. You've been listening to the Game on Glio podcast, the podcast that is designed to educate, advocate, and tell the real stories of those walking the journey of brain cancers such as glioblastoma and grief and loss. Like what you hear? Share us with others. Follow us on Instagram at Game on Glio Podcast, Facebook at Game on Glio, or visit our website or YouTube channel. You can find us anywhere podcasts are played.